Thank you very much, Timothy, for that background report. How far has Nigeria fared, and if we can actually achieve that goal of 2030. Now, joining us to begin our conversation, which borders on ending tuberculosis in Nigeria in commemoration of World Tuberculosis Day, which is every 24th of March globally. Let me introduce here in the studio Dr. Jafar Momodu, pulmonologist, fellow of the West African College of Physicians, National Hospital, Abuja. It's a pleasure to have you join us, Dr. Momodu.
Thank you so much. Thank you for having me.
Also joining us in the studio, we have here is Dr. Emperor Obochioma, team lead for Program Management Unit of the National Tuberculosis and Leprosy Control Program, Federal Ministry of Health and Social Welfare. Dr. Obochioma, welcome to Good Morning Nigeria.
Thank you for having me. Yeah.
All right, let's kickstart the conversation. Of course, we have other guests joining us outside Abuja studio, but that will be much later. But for now, let's begin the conversation. And Dr. Jafar Momodu would like you to set the ball rolling for us. What exactly is TB, and where are we in dealing with the disease?
Okay, thank you so much. Thank you very much in terms of asking that very, very important question. Because here you're asking me about what are we doing now currently with a very challenging, deadly infectious disease that has been with man since even before men became Homo sapiens. Let me put it, man being man. It's been there since the days of antiquity. It's quite important to know that it's quite deadly, and despite the fact that several strategies or things have been put in place to actually curb it, some of the risk factors that will entail you or an individual getting predisposed or having TB, they are still quite in our environment. They are still quite with us. So that's why we still, despite lives that have been saved, we still continue to battle this very deadly infectious organism called Mycobacterium tuberculosis. And to put it as much as we can, ending TB, it's actually what each and every one of us should aim at or prioritize. The NTB strategy is one of the strategies by the World Health Organization that's been put in place to try and curb this menace, which we call tuberculosis. And it started from several measures or strategies, of which we involve local, national, international bodies to actually come to combat it. And every March 24th is actually the World Tuberculosis Day, where we get to shout it out. Let me put it like this. We have to scream it out that, look, there are measures that are on ground to help curb this disease. And the more we are committed to it, the more we putting these measures in place, we'll be able to curb this. So our theme for this here is actually, yes, we can end TB because it's quite deadly. And there's a need to commit, to invest, and so that we can deliver these measures to curb TB.
Yes, we can curb it. And can you tell us where are we global average?
Okay, if TB is endemic in Nigeria, and I see it as, if we say where we are, is the fact that we can tentatively say we're putting as much as we can to actually curb the disease, okay, in terms of the strategies put in place to actually try to end this TB. But, you know, when you want to make a full assessment or a good, objective, sound note in terms of knowing where we are, we need to do some things. We need to do some evaluation in terms of how much of it do we have. If you look at your report, some of the data in terms of death rates might not be fully accounted for. Okay, some of the missed cases that are there, most especially even looking at children. I know we've had implementation whereby some people don't believe children can have TB. So there are some missed cases, and these missed cases is even attributed that for even one missed case, there are at least 15 persons that might actually then contact this, which is quite important. Then for those who have latent TB, they have TB infection but it's not active, these cases, how many of us are willing to go to get checked? So when we say where we are, we're actually in the, how do I put it now, in the need to get to where we need to get. So let me put it at that. I wouldn't say we are there already, but we just need to shout out the need that this is a deadly disease that kills more than you ever think of, and we need to try and champion whatever is on ground and even improve on it to get to where international health needs demand.
Okay, thank you.
There'll be no need to mince words as we celebrate, World Tuberculosis Day today, because it is, statistics shows that Nigeria has the highest burden in Africa and the 6th in the world. So it's important that we stress that, just so that action, can be taken to reduce some of these figures. But joining us now for the conversation, we have Professor Isa Sadiq Abubakar, Director, Center for Infectious Diseases Research, Bayero University, Kano. Many thanks, Professor Abubakar, for joining us.
Good morning, Nigerians. Thank you for having me.
All right, we'll let you settle in just a bit, and of course we'll get back to you. But let's talk to Dr. Ubochioma right here.
So let's get your perspective concerning the tuberculosis prevalence in Nigeria, and tell us what are the most common challenges faced by the patients in this country.
Thank you so much, and good morning, Nigeria. I think based on our information available within the program and within the country, we know that Nigeria has the highest burden in Africa, first in Africa, 6th globally, and among the 9 high burden countries, highest countries global, and we contribute more than almost among the people that contribute the highest number of TB disease globally. That's being said, we have done much as a country. The federal government have done much as a country. TB is a disease that is curable and can be treated. We also have done a lot of things in the area of trying to make sure that services are made available to patients in the country. Like I'll tell you, we have more than 20,000 health facilities available for people to access care in the country. We are even expanding more than 3,000 in this year to ensure that we have access to universal care. Through the support of Global Fund, federal governments have decided to use part of those money to provide universal care for those people by giving them insurance, free insurance service paid through that cost for about more than 120,000 patients in Nigeria, including those for HIV and for TB. And one of the key factors we face is, apart from access to care, is we know that the key problem of tuberculosis and the key challenge is poverty. So where there is poverty, the immune systems are low, and then the capacity for people to resist development of TB become very, very poor. So we shouldn't be much surprised that it's developed. We're having such situation in country, and as we battle poverty, I know that clearly that we will go up to develop to see how people can begin to resist tuberculosis in Nigeria.
Dr. Ubochioma, in your opening statement, you said the federal government is doing so much. I'd like you to tell us what exactly is so much on the part of the federal government, because there's a report with the U.S. funding, stopped. There's a report that from January to March this year, there's a $5 million funding gap as regards TB in this country. So what exactly is and then of course we know that the Global Fund is also a part of, support, in trying to end TB in Nigeria. Is the federal government really doing enough?
Okay, so I'll tell you that every country that has disease has support from different entities. But what I'll tell you in this situation that is very clear is that we have a very proactive minister in the name of Professor Pate, and in this situation, they flock into action and have received enough funding from the federal government to support, to make sure the gap for this period is over. Federal government alone is buying more than up to $50 million part of drugs to make sure to cover this gap. And I tell you, there are a lot of more on the board to make sure that the gap is not felt in country. If even the aspect of human resource, they have swung it to actually make sure that the human resource component where this USAID is supporting is the gaps are covered. So in terms of trying to make sure a meeting is held almost on weekly basis to make sure there is no gap felt. And that's why as a program, we are not feeling that initially it was a huge blow. However, within 2 weeks, the blow looked as if there is nothing that has else happened in country because of the effort of the minister to ensure that every Nigerian have access to care. And this government have shown very responsive action to that by even other countries can see that they can applaud the government for action they take, because there was a fear globally that Nigeria, being one of the highest burden countries in Africa, will swing back into the level where we were before. But with this effort, we are seeing that the narrative have actually changed. And
so are you saying there's improvement in terms of treatment and care?
There is. In fact, globally, Nigeria is recognized as one of the best performing programs in terms of tuberculosis globally, and have been applauded in several fora because of what they, coming from treatment coverage of 25% and 24% in 2019, and getting to treatment coverage of 75% in 2024. There's no country that have done that globally before. So these are just what we see as per the Nigerian government and the program, trying to make sure that access and care is provided. And we are the best in terms of, one of the best in terms of treatment success rate globally.
Fantastic. Many thanks, Dr. Ubochioma. Let's get to Professor Abubakar now, Director Center for Infectious Disease Research, Bayero University, Kano. Dr. Ubochioma says we are making progress, but, you know, reports kind of say something different. In 2023, over 361,000 cases were reported. Meaning there's some that are, you know, unreported, like Dr. Momodu rightly stated, and 26, which is actually 26% increase from 2022. And the report also says that 9% of these new cases are occurring in children. What exactly is the problem in dealing with this disease in Nigeria?
Thank you very much indeed. This should not be seen as a problem, actually, for people who know programs and for diseases that were hitherto difficult to handle as far as programs are concerned. There were fewer centers reporting cases and taking care of patients over time. But then with improvement in our health systems, more centers are coming on board to conduct the tests. More treatment centers are being identified and brought into the National TB and Leprosy Program. So we expect an increase in the detection rate. So the reported cases will definitely increase, as well as the number of people that are placed on treatment. So in a nutshell, unless this increase continues over a long-term period, we will, for the time being, consider this as an improvement in the program as far as detecting early diagnosis of the disease and then treatment of cases are concerned. But of course, we need to also increase in our efforts to conduct preventive measures, to carry out preventive measures at all levels, from the government, among healthcare workers, the communities, civil society organization, and all stakeholders need to work together to increase efforts aimed at prevention. But as far as this increase are concerned, in my opinion, it's a reflection of an improved performance by our health systems.
Professor, it's a reflection of improved performance. Tell us, please, how does TB actually affect the vulnerable people in the society? Like when I think the vulnerable population, I'm talking about children, pregnant women, and people living with HIV and AIDS.
Yeah, actually, tuberculosis, as earlier said, is a very infectious disease, and it is a devastating disease with a lot of complications, especially when untreated over a long-term period. So there are specific groups in the population that suffer the burden of tuberculosis more than others, just as the groups you mentioned. Of course, children who are supposed to be under the care of people whose immunity is not well developed start suffering from tuberculosis from their early days in life. And then for some of them, this will progress into secondary tuberculosis, and all the complications that tuberculosis is associated with may begin to manifest as time goes on. And these may include effects on the lungs, which from the common symptoms of cough, weight loss, night sweats, and fever, and coughing of blood, that is hemoptysis, it may progress into damaging the lungs and causing permanent lung damage, and so in some cases respiratory failure. So not only children, all the other groups, especially those living with HIV/AIDS, whose immunity has been devastated by the effect of the syndrome, that is by the HIV infection itself. Because of their poor immunity, there is possibility of all these lung effects and then extra pulmonary effect, that is effects of tuberculosis in other systems of the body, which include the bones, the joints, the kidney, the brain, the liver, and the spine. All these are manifestations that may also complicate tuberculosis. And of course, it can disseminate, spread throughout the disease, and in some cases cause septic shock and respiratory failure. And of course, the resulting effect is death. So vulnerable groups such as the people living with HIV/AIDS, children, and people with other diseases like diabetes mellitus, which is a risk factor for tuberculosis, and so on, they may suffer from these problems more than others. And of course, that include people who are chronic alcoholics, and it can even be a risk factor for developing cancer, because some of the effects in the lungs may create a hole, and in some cases create a scar in the lung tissue itself. And of course, over a long time period, this can lead to cancer of the lungs. So there are a lot of effects on especially vulnerable groups. And of course, apart from the pathological effect on the health of the body, of course, there is the socioeconomic burden. You know, families that have patients suffering from tuberculosis also suffer from catastrophic expenditure. Although the government is trying to provide anti-tuberculosis drugs, but some of these complications that may result from tuberculosis are not under the national TB and leprosy control programs. And of course, the patients have to find a way of getting those drugs and the other measures needed for the treatment of the overall complications. And that pushes vulnerable families into greater poverty, because they have to forego certain things like food, like money they will have used for shelter and clothing and other important things like the education of their children. They now have to divert it into taking care of the patient who is suffering from complications of tuberculosis. So these are, it has a very wide range of issues, from morbidity to mortality to heavy socioeconomic burden, and of course, long-lasting disability, because some of the long-term effects are complications that lead to disability and handicapping conditions. And of course, the people have to live with them.
All right, many thanks, Professor Abubakar, for your insights as regards that question. Let's get back here in the studio. Dr. Momodu, when Dr. Ubochioma spoke earlier, he talked about tuberculosis being a disease of poverty. And we know that, if you like, misinformation, lack of awareness, some myths are responsible for why this disease continues to remain with us in this country. I'd like you to shatter some of the myths, some of the misconceptions, some of the misinformation out there about tuberculosis. Does it mean that if you're wealthy, you can have tuberculosis? Is that what it means? Does it mean that if you do not cough out blood, like some would say, until you get to the point of coughing out blood, that's when you need to go get yourself tested? Just speak to us really, just so that we can educate Nigerians watching you at this moment.
Thank you so much for that question. And I'll specify on just answering as you've asked. So one thing is very common. If you look at what Prof has discussed, he made mention of the fact that poverty at the tail end, malnutrition, you understand, reduced immunity, okay? So TB can even occur in those who are immunocompetent. It means that someone who is healthy can also get TB. So it's just the amount of inoculum or the amount of the germs that gets into that person. And TB, if I may put, actually provokes every part of the immune system of the body. And it has ways of evading. So it's quite important that even when someone is healthy, if exposed enough to someone who has active TB, yes, definitely you can get TB. So it's not just only let's leaving it at the impoverished people with low immunity. Then also, people can have this infection, but they are not active because the body immune system has been able to curtail them to some point. So it tends latent. These people don't cough. These people don't have any of those symptoms. Okay, we call that latent TB. The need to screen should also be emphasized here, so that we'll be able to know, because once the immunity goes down in that particular kind of people, the disease becomes active, and then it could be a way of spreading the disease. So take into cognizance looking at the organisms being inside a human being, and this person is not getting symptoms. It can also, in a way, evade clinical decisions whereby people don't know that this person really has TB. In developed clients, I think they actually screen more or less people. I know Nigeria is trying its bit, you understand. They screen for latent TB, and as soon as that result comes out, they are treated. So TB quite endemic here. Most times we, how do I put it now? I think we have some certain predisposition to it, whereby we know that, oh, this is endemic here, this is quite plenty here, you understand, the need to treat. So there are some gaps in terms of that do we really treat latent TB within an TB endemic region, you understand, because almost, as you know, it's ubiquitous everywhere within our setting, and we're still trying to cope it. Then you also asked in terms of the myths, some of the myths, let's still demystify some other myths that are surrounding TB. So if you look into historical facts, you see that TB has had so many names over the past, coming from even the Victorian era. You have that the white plague, okay, it's been called consumption disease, a lot of things about it, and it's been associated with stigma, okay. So some people have that fear that once I'm diagnosed with TB, it's almost equivalent that I have HIV or my immunity is gone. So people tend to actually just try to take themselves out of that position of even getting tested. And I know if you look into the media, you've had jingles, enlightenment programs, cough above 2 weeks, please kindly see your doctor. These are some of the measures. It's not compulsory or compulsory that you must have cough out blood, which is the hemolysis, and then because fear of blood, definitely any human seeing blood would definitely rush to the hospital. So be it whether it's from any other disease, but blood is quite significant. People must rush down to the hospital. So it's not just that. TB can be quite silent, unlike some diseases that will just affect and everything comes up immediately. TB is one of the slowest growing bacterium that causes disease. And once it puts its effect, it's slow. That's why sometimes it's quite difficult to really hold it or catch it per se. So I don't know, that's in that way, you understand, if we put a high index of suspicion for it and actually treat anybody who coughs or who has been exposed to someone who had active TB, it can actually go a long way.
So if someone is inactive, if you have inactive TB, can you transfer to someone where it can become active?
Okay, so there's a possibility of transmission, but as we said, it's inactive. Okay, most times once it's active, the ease of transmission is quite increased. Okay,
so the inactive can just get full-blown TB.
So the inactive, yes, what it definitely means in terms of the inactive is that the body has body soldiers that just suppresses that organism, and it forms a tubercle within the person. If that tubercle is able to get out, definitely it can be infectious. But that's why if anybody has latent TB, the teaching now is to treat that latent TB so that that organism is destroyed in that person's body, so that the risk of transmission will not be increased if the person's immunity actually drops.
That takes us to the issue of diagnosis and treatment. Before we do that, I think our Zoom guest is ready. Yere, you have the details?
Yeah, we have joining us now Dr. Jean Louis Abena. He's a technical officer for tuberculosis at the World Health Organization Regional Office for Africa. He joins us all the way from Congo. Many thanks, Dr. Fo, for joining us. Good to see you.
Yeah, thank you. Nice to see you again.
So we'll get back to you. Just want you to settle down. Let's come back to Dr. Ubochioma. We're talking about this latent TB and others now, and this takes us to the issue of diagnosis and treatment. What are the most effective methods, actually, for diagnosing TB, in Nigeria, and how can these access to this method be improved on? When we talk about all these latent TB and all that?
Okay, I'll tell you that Nigeria have invested much in terms of diagnosis of tuberculosis. We have the primary diagnostic tool for Nigeria is molecular test tools, which comprises of GeneXpert with TrueNat machines and TB lab machines globally. We also before it used to be AIB microscopy, but with this new technology, they have actually outrun AIB microscopy and now became our primary diagnostic tool. And the advantage is that they can detect TB at the lowest level of infection and also manifestation. We have been able to establish more than 500 GeneXpert sites, more than 400 TrueNat sites, which is even ongoing currently in Nigeria. We have also more than 250 TB lamp sites currently in Nigeria made available to increase availability to care and support. Like I tell you, the focus of the government is to increase access to care and this thing. There is even a mechanism that makes it that in case a patient is where the molecular test is not available, funds are made available to transport samples from the site to where there are molecular tests in country. So these are the mechanisms that have been put in place to increase diagnosis of tuberculosis in the country. We also have up to 10 culture sites that can, in case you have resistance, those samples are transferred to those resistant sites to know the level of resistance and be able to place the person on the appropriate treatment. Even for this molecular test, one of the advantages of TB, GeneXpert and TrueNat is that they also have to dictate resistant pattern early enough to say this is likely a resistant case, not just the regular TB that you know. So we have, based on that, we have been able to create access in most of the states. There is no state that don't have more than 10 GeneXpert sites currently or molecular tests are available for them. We are still expanding. If you
have in communities as well?
Yes. Even there are ones that are on mobile vehicles, mobile like Keke, We have used Keke as a source of providing X-rays with artificial intelligence to screen patients in the community. We have more than currently, through the federal government and support of Global Fund, we have up to 400 gene-expert X-rays with artificial intelligence that once you snap this patient, it tells you that this is a case of TB that should have access to tests. And these are ongoing interventions in communities and in all over. And these are latest modern interventions in TB globally that have been so.
When you say community, we're talking about health centers, and do you have them in all?
I mean, in health centers, in community outreaches, in all those things, those machines are being used currently now. We have installed more than 250 of them. The remaining 100, almost 200, 100, 200 are still ongoing installation in most of the facilities. Even like in FCT, we have more than up to 10 in FCT. So these are just measures to make sure that access to diagnosis of tuberculosis is very, very easy. So what to do in the community component is that they take the community, do outreaches, and those who are most likely are given opportunity to take a picture, and those pictures identifies those who are likely to be TB, and samples are collected from those and sent to the molecular centers for diagnosis of TB in Nigeria. Some have been installed in health facilities, like 20 were installed in health facilities in a place like Kano. And what they do there is patients are referred from other centers to go and do tests. We're even engaging some private entities so that in case of there is a struck down in the health systems in Nigeria, patients still have access to care in the private facility. We have more than 3,000 health facilities where you can access TB services in private hospitals in Nigeria, yes.
Okay. Many thanks, Dr. Obuchioma. Let's get to Brazzaville, Congo, where Dr. Fu, who is our friend, joins us this morning. I'd like to find out what progress has been made in the African region towards ending tuberculosis, and what challenges remain.
Yeah, so the African region, speaking as a region, has made a lot of progress in finding more TB cases, and Nigeria is one good example of progress in expanding the number of centers diagnosing more TB patients. We have also succeeded in reducing the mortality, even if we are not reaching the 2025 milestone. So in terms of incidence reduction of people having TB and incidence of mortality. So these are the progress that we can display. And the African region was the second behind the Europe region, speaking about WHO region, in terms of progress. But Africa bear a quarter of the TB, the global TB burden, and also the mortality. So we had 2.5 million TB cases this year, and for mortality we had 400,000 lives that was claimed due to TB. That means that every second we are speaking, an African is dying due to TB-related complication or illness. And HIV is the main driver of the TB epidemic, but malnutrition is also one contributing factor for TB epidemics. So the other progress also we have made in terms of prevention. I've listened to the previous speaker. They mentioned that we administer preventive therapy to people who have latent TB, people living with HIV and contact cases. So these are the progress that the region can display, but there's still room for improvement on this aspect. Over to you.
Okay, Dr. Fo, thank you for your opening remarks there, and for telling us the commitments on tuberculosis across the region. Can you also explain to us how these commitments will be funded and implemented?
Yeah, so the question of commitment is very, very actual and is really the thematic of this World TB Day celebration. All is about investing. If you are committed, you put the money. So what we see in terms of commitment, proof of commitment, that is budget, we have a trend of decreasing both external and internal resources. So this is really a matter of concern in the region. So we need $4 billion for each year for TB control in Africa. We just have 0.9 billion dollar for the response. So we are really on. We are not meeting the needs to really fight against TB and meet our commitment of ending TB by the year 2013. So it's just an opportunity to call the government to sustain their investment, to invest more, to close the gap of what is going on about the external funding that is not really granted for all the country. So this is actual situation. We need more local, more domestic resources to close the gap of TB financing, and show also proof of commitment. So this is an appeal for our government as an African, that we need to really reappropriate the fight against TB by investing in TB. It's not a spending, it's an investment, because when you invest in TB, you have a return on investment, you have better healthy population, and this is one of the first infectious agents that are claiming the life of Africans. So let's fight against TB and then deal after for other infectious diseases that are less dangerous or also matter of concern. But we need to invest for TB control in the region. Over.
Talking about closing the funding gap, I'd like to remain with you. What would be your recommendation in that regard? I mean, we know that African countries are dealing with quite a lot. Security is key, education, even in the health sector. There are other diseases that, are causing, a lot of concern, in the African region. So how would you expect that this funding gap will be closed? I just want to know what your recommendations will be.
We are really, Nigeria, speaking to you, and we know that we made commitment in Abuja to have a significant part of our budget devoted to health. We know that we have a lot of constraints, but what I can advise to government is to really set clear priorities. So we need to invest in diagnostic tools. So everyone should have access of TB diagnostic, and once you are diagnosed as TB, we need to have the drugs. This is the minimum we can really secure in terms of priority, and also the functioning or the running budget of the TB programs. And these are the priority we need to really fund. So we need the drugs and the diagnostic. These are key entrants we need to secure before looking of other parts of the TB response in terms of budget. So we need to secure it, and we are looking in the newspaper some shortage of medicine across the continent, and this is not really fair that you are being diagnosed of curable disease and you don't have access to the medicine, or you go to the facility, so there's shortage of reagent for TB diagnostic. So this happened in our region, and this should be a priority for our leaders to close this gap and to secure these resources and to avoid stock out. It's better to prevent, to really strengthen the chain of procurement, give them better resources, plan in advance, pay your manufacturer of the drug and everything to make sure that the patient will have all the intrants when you go to the facility to seek care. That's my plea today.
Thank you very much, Dr. Fo. Now let's go to our Kano studio, where we still have Professor Abubakar. Professor Abubakar, I want you to, we talked about the funding, we've talked about the diagnosis. Let's talk about the treatment now. And what are the standard treatment for protocol for tuberculosis in the country, in Nigeria? And how can the treatment adherence be improved on?
Yeah, thank you very much indeed. The Nigerian National Tuberculosis and Leprosy Control Program adopts what we call the strategy that we refer to as directly observed therapy short course, as opposed to the past treatments that probably will take 2 years, and it will involve 3 months of injection followed by the swallowing of some other drugs that will last up to over 24 months. The directly observed therapy short course strategy, which started from the Stop TB strategy that, and then that later we are now adopting End TB strategy, which also continues with the directly observed therapy short course, which in short we call DOTS strategy, will now require that a patient who is being treated for tuberculosis will undergo treatment for 2 months intensive therapy and then 4 months continuation therapy using a number of drugs that are standard if we are treating a patient as a first-line treatment, no resistance, fresh treatment. And of course, some of these other strategies, the issues will involve modifications here and there depending on the conditions that may also be associated with the tuberculosis. These drugs are being provided by the national program. So in the strategy, it requires that a person who has been nominated, a health worker, who may be a junior community health extension worker, has to observe as the patient swallows the medication and then record that. That ensures adherence to treatment. And for people who might forget, sometimes there are strategies, different strategies that researchers have brought forward, which are adopted and are recommended so that the patients will be reminded. But in a nutshell, the main strategy is to ensure that the person swallows the drug and it is recorded so that we will account for all the days that the patient is required to take the drugs, and we are assured that the patient has adhered to the treatment. In most cases, if these are adhered to, of course, the patient gets cured of tuberculosis completely. There are situations where some people default, and then we may have some few situations of relapse and things like that. So such will require modification of the treatment depending on, but this is to be decided by the attending physicians who are treating the patient.
Abubakar, from what you've said, tuberculosis seems to be difficult, really. Once it's diagnosed and then you're placed on treatment, you've talked about the period where the patient needs to be on medication. And I'm just thinking, for someone who is already poor, has been diagnosed with tuberculosis, has to go to the health facility every day to get the medication. That's, some kind of cost. Then the treatment period, of course, maybe for a farmer or for someone who has a business and all of that, a lot of things, would interfere with, adherence to the treatment process. Is Nigeria doing anything in terms of research, in terms of, finding ways on how we can handle this disease better? Or you think that, we just have to stick with what is available at the moment? And then, of course, I have interacted with patients who have undergone tuberculosis treatment. The drug itself, quite cumbersome to swallow. I'm wondering how a child, who is placed on such a medication will be able to survive with it. So is there any, are we doing anything just so that we can reform all of this?
Yes, definitely there are a number of researches that have been conducted to improve on the treatment strategies. And of course, this, in some cases, a patient doesn't need to come to the health facility every day to collect the drug and swallow. They are given the drugs for few days, but then, of course, a caregiver who may be a relative of the patient helps to ensure that the patient adheres to the treatment. And the period for which they get the drugs vary depending on the places and depending on how educated or how enlightened you see that the patients are adhering. That is the number of visits to the health facility to collect their consignment for a period. And of course, these have been individualized depending on the sites. But then these help to reduce the number of visits and place burden on the patient payment for transport to get to the health facility. So this is one aspect of it. But the other aspect has to do with the difficulty in swallowing the drugs, as you mentioned. For children, the same drugs are compounded. So by compounding of the drugs, we mean that they are converted into liquid or semi-liquid form so that the child will find it a lot easier to swallow when you convert this drug that hitherto had been a tablet. Now you are placing it inside a liquid drug like multivitamin, which is in syrup form, and then you are adjusting the strength to respond to the needs of the child. So when you have that, and of course, as you know, multivitamins are sweet to taste, and children like things that are sweet, it becomes a lot easier for the child to accept the drug, and then, of course, the treatment is maintained. So there are a lot of strategies, as I said, and these are based on evidences from researches trying to modify and make it easier for the patient to ensure adherence. And some of them will require text messages, some of them will require a caregiver of the patient who is very close to the person. For example, the wife of a patient or the husband of the wife, depending on who we are dealing with. They are the ones that are brought on board to ensure that they help the patient to remember to take the medication, and then to help in seeing the patient swallowing and then reporting to the healthcare givers. So a number of strategies. Thank you.
Thank you, Prof. But before we let you go, I just want to ask this one question. How do you handle the issues of drug resistance?
Well, drug resistance in tuberculosis management, the important ones are multi-drug resistant treatment and extremely multi-drug resistant treatment. That is an advanced strategy that is needed to handle such things. And of course, when they are detected, there are tests, specific tests, as Dr. earlier mentioned. Using the TrueCard technology, you can diagnose it. So such patients are separated from the normal clinics where the normal non-resistant treatments are being conducted. In fact, in many hospitals that handle serious tuberculosis, not just the simpler ones, there are wards specifically allocated for patients like that. They are isolated from the general public so that they can not be spreading the multi-drug resistant type of Mycobacterium tuberculosis. They are kept there for a period of time while they are under treatment, and then when it is felt that they are no more infectious, then they can be discharged, and then they can go about their but of course with a lot of monitoring. So, and then the drugs that are used, of course, are a little bit different from the normal drugs that you use, the common ones that you use for treating fresh cases. It's a serious type of tuberculosis. Even from the location of where the patients are kept, you'll notice that it is not something that you can handle carelessly, because they are kept in a place where it is not easy for them to mix with other people that are not infected with multi-drug resistant tuberculosis.
Thank you very much, Prof. We'll go on a break now. When we come back, we'll look at the issue of prevention and control. Stay with us.
All right, welcome back. It's still Good Morning in Nigeria, live on the network service of the NTA, and we're still discussing tuberculosis and how we can end it in Nigeria. Our guests are still very much with us, and I would like to get to Dr. Jafar Mamadou, of course, as we begin to round up the conversation. We're looking at ways we can, prevent and, of course, eradicate the disease completely from our society. But I would like to focus on prevention, really. What can we do? Like they say, prevention is better than cure, right? So in terms of tuberculosis, what's the way out?
Thank you so much for that question. Preventive measures, what I can actually say is that you are responsible for your health. You're your first doctor, okay? And there are some practices that can increase the risk of having TB. So let's start with practices. Those who drink, binge alcoholic, people who smoke, this puts the lungs in a position whereby the immunity is quite reduced. What about other preventive measures? We know we have the BCG vaccine for children, of which they should be vaccinated. Some people actually have the fright now of, in quotes, vaccination. The scare, most especially coming in from recent epidemic that happened. But vaccinating children from birth is very, very important. Then also preventive measures too that can be coming in from those that have latent TB, whereby we quickly treat them so it prevents this spread. Then also in terms of our own judgment for the clinicians, getting these people tested early enough as to treat them so that it prevents the spread. Then I also would talk about it, as I've said before, your health is wealth, and you have to prioritize that need to be able to reduce things that will affect you. I know poverty is not something you can just come and eradicate just in a day, but I think with the basic understanding of life and what you need to do, there are some things that you should put in place to actually help yourself, financial-wise, okay? And also getting more education about this particular condition, which is quite important. I don't want to bog through, normally we have levels of principles whereby we prevent diseases, starting from even the primordial level, whereby we have commitment from the community, political will of the government in trying to ensure that it addresses the situation by providing some like the TB programs, strategies used to curb the disease. Then also in the primary sector or the primary level, where we are also educating the populace about this deadly infectious disease, of which we get them to know that this it's a curable, preventable and curable disease. For someone who has been coughing for long, even sneezing, singing near you, has the probability of dispensing this. Then looking at the secondary level, where the hospitals are, early diagnosis and treatment of these diseases, and then looking at secondary level treating. The tertiary will help take care of some of the complications that might arise from the TB treatment. Then also continuary level of or the prevention, of which we've seen that more AI in terms of even the card for TB to diagnose this disease as early as possible to be able to curb the menace.
Okay, thank you, Dr. Momodu. I want to come to you, Dr. Obochiama, but we need to go to our Zoom guest. Okay, we've lost him. So let's just let me just come to you now. The other time you wanted to speak more on the issue of TB, the treatment that we have drug resistance issue. You would like to expand more on that. But there is issue. We know that tuberculosis is a contagious disease. And we know we have it in the markets, in the prisons, and all that. So, what exactly do you think government should do, in these instances?
Okay, thank you so much. For government, I think the majority of social welfare package and also trying to battle things like poverty and increases people's capacity to have access to common things in life is very key, which is a long-term effect. But I think also providing, like you talk about prisons, providing a prison service where there is ventilation is very key. Identifying, screening, and like now what we're doing currently is that we're providing screening in the prisons and all the
correctional centers,
all the correctional centers, and also at the at everywhere you have a congregate of people being arrested for one reason or the other, or waiting for trials. We try to provide those services there to screen, and the idea is early identification, treatment, and then for those who are also in the prison that have contact with these patients, we also provide them with preventive drugs to make sure that they don't develop TB at the end of the day. So those services we are providing, we are using currently now. The plan is to go ahead with we have done that in so many prisons where we are using the CAT4 TB X-ray with artificial intelligence to say we screen every patient.
So you have screening in correctional centers right
yes.
now.
Correctional centers, we have screening ongoing. We've been doing what we call massive screening to make sure that everybody at each point in time, the idea is that at least twice in a year, we should have access to screen all of them and then provide any one of them with treatment. And the treatment, like we said, is free. It's not charged, it's free. Prevention is also free in the country, and all the diagnostic facilities are also 100% free. They don't pay for those services. So that is very key for what we are doing. And for now, I think every contact, for now what we're also doing is that for community preventions, we are also making sure that early diagnosis is key, because when you diagnose and treat, and TB is one disease, even with the infectious level, within 2 weeks of initiating treatment, the person starts being infectious. Almost 80 to 90% infectious will go down. So it becomes that the person is free to to continue his life in the society within 2 weeks. And what with early identification and that treatment, which stops the spread of the disease, one, and then for every contact of those patients, we also give them preventive treatment. We have moved from long-term preventive treatment of 6 months to getting to 3 months treatment now, because the new drug we are putting in since this year is now the drugs that we, instead of them putting them on 6 months prevention, we are now going to put them on 3 months prevention. And the idea is to make sure that those contacts, which if you remember when Doc was saying, he was talking about the volume of inhaled bacteria the person have inhaled over a period of time, because the patient is a family member. All of them have been in the same house. Most of the time these houses are not well ventilated, so they are inhaling as the person is coughing out the bacteria. bacteria. So as the bacteria is being coughed out, the family members are inhaling. So to make sure nobody later develops the tuberculosis, what we do is that we also place the entire family members and even those within the environment that have had contact with that patient to place them on prevention.
All right, Dr. Ubochioma, I'm thinking, is there a possibility that someone who's been treated, for tuberculosis to come down again? Does treatment mean having immunity over it?
No, it doesn't. The person can come back. The patient can come back. The level of coming back, some people can be declared cured and they get infected in the community, and then they reappear. Okay, we tag those ones as maybe we say relapse, that the patient had been treated before, but he relapsed. Some of them are those who also were treated, but were not cured, but later they also come back with the disease because they started feeling fine and this thing. So we tag all of them as cases of retreatment.
Okay.
They are all retreatment cases who have actually been exposed to TB treatment initially, but however, they came back again with TB. And some of them can be also because of they were unable to complete the treatment ab initio, which is where we fear issue of them becoming resistant to
the drugs. Many thanks.
What about the issue of tracing and surveillance system? What kind of tracing and surveillance system do you have?
Okay, what we do is once a patient is diagnosed, all the people within the environment are screened for TB, and those who are not positive for the TB are now placed on prevention, while those who are positive for TB are placed on treatment in the community. We also have what we call early warning signs, where what we do is an AI system where all patients, when patients are being registered in the AI system, they give you an environment where there is tendency for high volume of TB cases. So we go for a community outreach in that community to make sure that we comb all those areas to prevent. Because when we now find a situation whereby you find in a small locality there are 10 TB cases diagnosed from that center, it means there is something happening within that environment. So that AI tells you through the community system that the community should visit that place for this. So they go there with artificial X-ray with artificial intelligence, screen the people, and after screening them, everybody identified by the artificial intelligence to be by the X-ray to be a presumptive case of TB. That's you are thinking that this person may have TB. The person's sample is taken to the nearest molecular lab where it is tested for TB, and those that are positive are placed on treatment. All
right, Professor Abubakar, as we round up the conversation, I'd like you to speak about what can be done better, in health centers that have to deal with patients with tuberculosis, and medical personnel also. They have a role to play in all of this. So I'd like you to speak around that as a way to end tuberculosis by 2030.
Okay, thank you very much indeed. Generally, we need to improve on our health systems. And of course, when we talk about the health system, in Nigeria, we have the building blocks are up to 8. Part of them have to do with things outside the health sector, but majority of them are within the health sector. And of course, the health centers are the sites where we see real reflection of the health sector. And of course, that is service delivery. And for service delivery to improve, you need to have standard operating procedures which must be adhered to by all the personnel in delivering their services. Of course, from the time that you receive a patient, how you detect the disease, the diagnosis, the treatment, and of course, the follow-up and everything you will do to the patients are to be guided by a standard operating procedure, and people must be seen to be adhering to them. Secondly, we need a lot of teamwork. Our health workers need to work in unison, not to have unnecessary interprofessional rivalry, and everybody's job description must be followed. and we must respect the contributions by others. And of course, our health workers need training and retraining, and in some cases, reorientation based on available evidences that are emerging, best practices from researchers and from centers that are doing very well and have been succeeding in managing the cases of tuberculosis, and that is the way to go. And of course, we need to increase the number of the workforce. Our available health personnel need to be improved upon to ensure that we are able to deliver. We shouldn't be having a situation where few workers have to do with a lot of work, and that does not ensure quality. And then supervision is very, very important. Whatever the workers are doing, if they are not being supervised, there is really not a feeling of motivation, and some may derail from good practices. And then we should ensure the availability of the drugs. Of course, we've had, and it is reassuring from the Federal Ministry of Health, that the gaps are being closed, because we have encountered a situation where in some of our health facilities there were shortages of drugs for some times. But of course, I can tell you now there are available drugs, at least in the places that I practice. So we shouldn't even have a situation where we'll be having out of stock for some of these very, very important drugs and consumables, reagents that we need. We must ensure supply is being steady without any disruption. And of course, the funding, even at the health facility level, a lot of resources, financial resources are needed to ensure the services are going on undisrupted. So whoever is responsible, from the level of government to the management of the health facilities, they must ensure that this funding is adequate, and it should be based on needs, not just a situation where people budget and then the boss at the top will just reduce certain amount and give them. It should match the requirements adequately. And of course, everything that we should do in planning, we must ensure that there are evidences from our health information. So whatever, based on the number of cases that we have seen, we should plan everything based on that, forecasting what will happen in the future. So health information is very, very key, and establishing partnership with the community, the civil society organization, the government, the non-governmental organization, and even international partners that are supposed to be assisting us with funding. This is very, very key to ensuring steady supply of services, undisrupted, and then good quality of services are being provided to the people who need it. So we need to foster collaboration with everybody that can make a difference so that the services will be good. And nothing short of that will be good for the health sector. And of course, by the time we ensure all these things, I believe that we're going to have a lot of improvement in not only ending tuberculosis, but improving the health system generally, devoid of diseases in most cases. Thank you very much.
Prof. Abubakar, for that. Going forward now, I mean, the need for us to collaborate, I mean, to get more stakeholders involved, like civil society groups and private sector, like what the First Lady is doing now, Senator Oluremi Tinubu, trying to end TB in Nigeria. How do we go about that? I mean, getting more stakeholders involved in this fight. Dr. Momodu.
Okay. Thank you so much.
Just in 1 minute?
1 minute, okay, thank you so much. I think it's quite applaudable seeing the First Lady doing this, and it's more like the keeping the torch burning, of which other individuals, both local, national, international, can also imitate and follow suit to help curb diseases. It's quite important at this particular time time of our lives whereby I've seen that in every community now, you have to own up for your health. The United States has actually dropped out some fundings. So we need to really commit ourselves at this particular point, wherein we can get these personalities who are willing to actually help out, okay, and support this TB program is very important. And like Prof said, you're investing, you're not just donating. And we'll have better health care for people who are living in this TB endemic area. And also a call too for clinicians, the healthcare workers, all other people on ground to deliver these particular measures to help achieve these goals.
Thank you so much. I think that's a fine way to leave the conversation. Many thanks, gentlemen, for joining us. Dr. Jafar Mamadou, pulmonologist, fellow of the West African College of Physicians, National Hospital of Abuja. Many thanks for being our guest.
Thank you
and
so much.
We hope that you continue to ensure that we stamp out TB. Dr. Emperor Obochioma, team lead for Program Management Unit of the National Tuberculosis and Leprosy Control Program, Federal Ministry of Health and Social Welfare. It was a delight to have you.
Thank you.
All right, we also appreciate Professor Isa Sadiq Abubakar, Director, Center for Infectious Diseases Research, Bayero University, Kano. Many thanks for joining us, Prof. We do appreciate you sincerely.
Thank you very much for having me.
And of course, I would also like to thank Dr. Jean Louis Sabina Fo, who joined us from Brazzaville, the Republic of Congo, in the course of the conversation. He is a technical officer for tuberculosis at the World Health Organization Regional Office for Africa. So that's our package this Monday on Good Morning Nigeria. Take care of your health. And of course, let's end tuberculosis in Nigeria. I'm Henry John.
And I'm Ademola Adeoye. Stay safe.